Okay. So we are live. Welcome everybody to our second session of Webinar Wednesday, where we're going to be talking about disparities in healthcare and health policy. I am going to be your moderator today. My name is Katie Terry. I am working in the Department of Health Management and Informatics. Our two panelists today are Ms. Danielle Atkins and Catherine Thompson. I'm going to go ahead and pass it off to them to introduce themselves, and we will get started. Go ahead, Danielle.
Thank you. Good afternoon, and thank you so much for joining us. My name is Danielle Atkins. I am a faculty member in the Department of Health Management and Informatics in the College of Community Innovation and Education, and my research focuses on health policy. I'm particularly interested in maternal, infant, reproductive health, and also substance use disorder policy. And my background is I graduated from the University of Tennessee with a degree in psychology and a minor in music. And then I went on to the University of Georgia and got my master's of public administration and my PhD in public administration and policy, where I focused on health policy. I went back to Tennessee as a faculty member for a few years, and then came down to UCF and have been in the department ever since. I really enjoy my work here, especially with the students. And so that's a nice segue. I'm really thrilled to have one of my former students join me here on this webinar today. And I'll let Catherine go ahead and introduce herself.
Thank you so much. Hi, everyone. My name is Catherine Thompson. I'm actually a third-year PhD student at the Brown University School of Public Health. My primary research interests is focused on Medicaid policy, specifically how Medicaid policy pertains to HIV-positive women on Medicaid, so their birth outcomes, their access to healthcare services, and also their adherence and persistence to antiretroviral therapy. A little bit of background about myself. Yes, I used to be one of Dr. Danielle Atkins' students when I was at UCF. I got my undergraduate degree at UCF in health sciences preclinical, took some time off, and then I came back and got my master's at UCF in my master's of health administration within the same department. And I used to work with Danielle, as I said, she was my first primary mentor, kind of like led me on the path of research. But thank you guys for inviting me here today.
Okay, great. So I'm going to take over the first part of the presentation here. And then at the end, you'll get to hear a little bit more about Catherine's story and her progression into a PhD program from her studies in our department at UCF. And then you'll get to see a little bit about her own research that she's doing now. So I want to propose a question to you first off. I want you to consider the following contributors to premature death. And think about ranking them from highest to lowest. So if you've got a piece of paper and a pencil, just take some time, or you can put it in the chat if you'd like, and we can talk about it afterward. But these include environmental exposures, genetic predisposition, healthcare, social circumstances, and behavioral patterns. So just take a second, think about these, think about the one that would be the most influential as a contributor to premature death. Maybe think about the one that you think would have the least influence. So we can move to the next slide, and I'll show you actually how this kind of breaks out. So this is from a 2007 article in the New England Journal of Medicine. So you can see here the proportional contribution to premature death, and I think it's a little bit different than what we all might expect. So you can see that the most significant as far as the size of a contributor to premature death is your behavioral patterns. So maybe that's not so surprising to us that, smoking, exercise, nutrition, stress, right? A lot of those different kinds of things contribute to premature death. And then followed by that is genetic predisposition. But I think one of the surprising ones, or at least in my experience with most of my students, is that healthcare is about 10%. So it's a pretty small contributor to premature death. Not that it's insignificant, but behavioral patterns and genetic predisposition make up the majority. But also that social circumstances make up 15% of the contributor to premature death. And we're going to talk a little bit more throughout the course of this presentation about what those social circumstances might be, and how they may be related to ultimately your health outcomes, and that there are differences across different population groups with respect to how these social circumstances ultimately affect health, across race and ethnicity, socioeconomic status, age, location, gender, disability status, sexual orientation, and so many more, really. So we can go to the next slide and talk a little bit about what are health disparities. So disparity is really just another word for a difference. It could be differences between groups in health insurance coverage, access to and use of care. It could be quality of care across different populations. And then there's also differences that aren't necessarily explained by your health needs. So in this definition, you can see that it says health and healthcare disparities are differences in health and healthcare between groups. But it's important to recognize that these are closely linked with social, economic, and or environmental disadvantage. And so if you go back to the previous slide in your mind and think about that 15% chunk that could be a contributor to premature death, and then recognize that that's on average, right? And that might be different for different populations, different subpopulations, different groups. So again, this can occur across many dimensions, including race and ethnicity, socioeconomic status, etc. And I'm going to go into a specific example here in just a moment, although the examples, frankly, abound. There are very many. And we also often talk about health inequality and inequity when we think about disparities as well. So we can move to the next slide. So here are what are called the social determinants of health. So when you think about that social circumstances chunk of that pie chart, these are some of the things that we typically think of when we think of social determinants of health. So these are things, outside of your genetic predisposition, outside of your behaviors, right, necessarily. So for example, economic stability is one social determinant of health. There's something called the health wealth gradient. So higher income, higher wealth, right, is associated with better health outcomes, as is education. Education is significantly correlated to your health outcomes. So more education is associated with better health outcomes. So economic stability can come in many forms. It could be employment, income, expenses. You have to kind of consider the whole picture, your debt, medical bills, and other types of support. So with respect to education, health literacy is important. We know that there are differences in health literacy, and, understanding what your physician is saying or reading the prescription directions can all be very confusing for us. So that's a big part, right? Language barriers. If your healthcare provider doesn't have language interpreter services or material in other languages, right? That might be a barrier for you. Early childhood education matters, vocational training, higher education, and you can see how these are also linked to income, right? And they kind of maybe affect each other. And one of the interesting, I'm interested in maternal and infant health. And one of the disparities, very large disparity, is maternal mortality between Black and white women. So Black women are 3 times more likely than white women to die, right, during or shortly after childbirth. And this is the case, it's much higher for Black women, even if you account for education, right? So even when Black women have higher education, that gap doesn't shrink like you might expect it would, So there are other things going on. It's not just, education. There's other pieces like systemic racism that certainly play a role in health outcomes as well. Okay, so neighborhood and physical environment. So, if you don't feel safe in your neighborhood and you can't walk outside or go play, that certainly is related to your health outcomes, your mental health, your activity level, transportation. If you don't have transportation, how do you get to work, right? Parks, playgrounds, the built environment around us matters a lot. Walkability, sidewalks or not. And this can all vary by zip code and geography, even in a small region. You could look at different parts of Orlando and see disparities in income. And we'll talk specifically about one example in just a little bit. Food insecurity. So that's when you don't know where your next meal is coming from. And hunger is really hard to see, right? You can't necessarily look at a person and say, oh, that person's hungry. They don't know where their next meal is coming from. And then there's this problem of food deserts. So a food desert is when you don't have access to fresh, healthy food. So you don't have access to a Publix within a certain distance, right? And you have to rely on more shelf-stable options, which are less, right, healthy for us. Community and social context also matters. Support systems, community engagement. There's a book, Bowling Alone, that talks about, the disintegration of the social fabric of the country and how that relates to health and other types of outcomes. Now, we used to, have bowling leagues, and now we bowl alone, and what that means. And then you can think about that in the context of, social media and the isolation associated with that. And then, of course, right now, with COVID, right? And we know that we expect, and we're already seeing some, outcomes with respect to mental health and other health outcomes. And the healthcare system, of course, plays a role as well. And so you can see that all of these, right, kind of interplay with each other, but then also are related to health outcomes like mortality, so that's death, morbidity, illness, life expectancy, your expenditures, status, and functional limitations. So we can go on to the next slide. And I just want to talk about one of the specific social determinants of health here, which is income. So you can see that incomes are increasing, from the late 60s to the mid 2010s, but there's a pretty significant gap between white and Asian incomes and Black and Hispanic or Latino incomes, on the order of about $30,000, right? And this is the median income. This isn't the average, right? So there is this big gap. We know it's related to health outcomes. So let's go to the next slide. We also know that in the United States, most people get their health insurance through employer-sponsored health insurance. They get it as a part of their job. So this picture, this graph shows uninsured rates for the non-elderly population, right? So these are the non-Medicare population by race and ethnicity from 2010 to 2018. And what you can see is, like income, there are differences or disparities in rates of uninsurance by race and ethnicity. So you can see, right, that, so the top line here, the light blue line, American Indians and Alaska Natives are most likely to be uninsured, 20% or so in 2018, 33% in 2010, followed by Hispanic, then Black, and then you see, white and Asian very unlikely to be uninsured, particularly relative to these other populations. So not only is this related to income, it's also related to access to care. So income is a social determinant of health. Insurance, of course, affects whether or not you can, see a physician or another healthcare provider, and the ability to pay for that care. I would show you, so what happened between, 2012, 2014, 2015, the Affordable Care Act, right? And so we see some decreases in uninsurance, and there's quite a bit of research, showing that Medicaid expansion and other reforms are associated with these declines in uninsurance. Okay, so we know that there's disparities in income. We know that there's disparities in insurance. Let's go to the next slide. So right now we're in the midst of a pandemic. So this shows the share of adults at risk of serious illness if they're infected with coronavirus by income. So if you make less than $15,000, right, and this is your yearly household income, 35% of people in that income category are going to have serious illness if infected with coronavirus. Then you see it decreases, right? And it's, an order of magnitude, right, different for households with $50,000 or more. And you could think this might change as you go up and up, right? So let's take it a step further. We know that income's related to health. We see that if you have higher incomes, you're less likely to have severe illness associated with coronavirus. Let's go to the next slide. We also know that your environment and your neighborhood is a social determinant of health as well. You can go back one. Okay, so this is a Huffington Post article from 2017, and that area right there is one of Orlando's poorest neighborhoods in the Paramore area, historically Black community. And what do you see surrounding the neighborhood? I-4, the 408, lots of traffic, right? Really in a small area. So you can imagine not only there's noise, but also air pollution. So this bottom picture is dust that came through this woman's air conditioning unit in her apartment in Griffin Park. So you can imagine what that might mean for your respiratory function, right? So Jacqueline Young was a veteran of the US military, and her daughter suffered from respiratory illness, right? Most likely associated with the air pollution that's coming from all of that traffic, right? Okay, so let's go to the next one. So now let's think about disparities in air pollution burden. So you can see this map shows air pollution burden. So this is the proportional particulate matter. So I'm not an environmental scientist, but this is a measure of air pollution burden. So you can see you go from blue, that's low, to really dark red, that's high. And this is the burden for non-whites. So basically the big takeaway here is non-white people face higher exposure, right, to air pollution in all but 4 states. Non-white people face higher exposures than white people. And those states are Maryland, New Mexico, North Dakota, and West Virginia, and Washington, D.C. Indiana, Alabama, people of color are exposed to roughly twice as much particulate air pollution than white people. So we've got differences in incomes related to health, differences in insurance related to health, neighborhood context and air pollution, right? Also related to health. So you can kind of see where this all comes together to create this fabric that undergirds these disparities that we see. Okay, we can go to the next slide. Let's bring it back around to COVID. So COVID and air pollution, what do we know? So COVID is higher. COVID rates are higher in areas with higher air pollution. Okay, so then let's take it to the next step. This should surprise nobody given what we've learned so far, I think, although this was a very shocking finding, right? When we saw these disparities in death rates and illness with respect to COVID across race and ethnicity, right? But we can see here that there are large disparities in serious illness for those infected with coronavirus than white adults. So especially for American Indian, Alaska Natives, Blacks, right? 34%, 27%, compared to 21% for whites. Okay, so I think this is an example, and there are so many more, of disparities. And one of the things that I always challenge my students to think about in the first policy class is, please give me an example of a policy that isn't related to health. And I would challenge you to think about that too throughout the rest of this presentation. Because, you know, economic policy, environmental policy, transportation policy, your water, your food, your medicine, right? All these things are related to your health. So this is a snapshot from an article in Health Affairs. It's a health policy brief about health income and poverty and the relationship between these things. Kind of an example of what we discussed, a small example, right, of that today. And basically the takeaway is that there's a lot of evidence linking income and health. And so policies promoting economic equity might have positive spillovers to health. So for example, policies that supplement income, improve educational opportunity, housing, social mobility. This can all reduce poverty, and then you can see that trickle down, right, eventually to health. Now, these take a while, but I think you can see based on this kind of story that might really improve health, and not only for low-income individuals, but also people in the middle class. So thank you for taking the time, and I look forward to your questions, and I'm excited for you to hear from Catherine.
Awesome. Thank you so much. So first I'm kind of going to get into kind of my own personal journey, and then I'll kind of hop back into talking about, health disparities and then also health policy, and really kind of bring that home about how I like to say how public policy is health policy, and how they kind of like really kind of ties everything together. But again, my name is Catherine Thompson. I am just now starting my third year in my PhD program in health services research here at Brown University. My journey is definitely not the traditional one. I changed my mind time and time again. And then I was also introduced to some amazing individuals who helped guide me kind of through my journey, my decisions in my life, including Dr. Danielle Atkins. So I'm very, very, very appreciative of her. I started off at UCF getting my undergrad degree in health sciences preclinical. I originally wanted to become a doctor, and I was like, oh, this is what I'm going to do. Got into my last year, my senior year, and decided like, wow, I really do not want to treat patients. This isn't exactly what I feel I'm called to do. And thankfully, through a program that I was mentoring with Florida State College of Medicine, I was offered a full-time position directly out of undergrad. They had a lot of faith in me, I know, through my old mentor. But it was probably one of the best decisions I ever did. So for about 2.5 years, I served as the coordinator for the Florida State University College of Medicine Orlando campus. And I took seed money from Florida State University and also from the city of Orlando to start like this outreach program for students within inner city Orlando who wanted to be involved in some type of health career, whether that was, working as like a frontline worker, or that was working as a researcher, or getting into other different types of or healthcare management. So I did that for about 2.5 years. And while I was doing that job, I actually decided I wanted to go back and get my master's, just because I fell in love with what I was doing and I wanted to continue. And so that's when I entered the department for the Master's of Health Administration. And that's actually where I met Dr. Danielle Atkins. And, through taking classes and meeting some really awesome colleagues who are still my friends today, still talking today, I knew that my path was going to be a little different just because, I was doing these internships and I told myself I was going to be a hospital executive. And I kind of hit that wall again where I felt like I wasn't fulfilling exactly what I was called to do, or what I wanted to do. And so Dr. Atkins kind of like took me on her wing a little bit and she was just like, okay, if that's not what you want to do, then great. Then let's figure something else out. And this is kind of how I got started with research. Here we're going to teach you how to code. We are going to teach you how to look up research. You're going to be my research assistant. And through those mechanisms of working with her, and then also the McNair office at the University of Central Florida, I really fell in love with disparities research. And during my last semester of my master's program, I actually spent the last 4 months at Brown University because I got an internship opportunity to work with the professor that I'm currently working with now, my current mentor, Dr. Ira Wilson. And through kind of that journey, guidance, and having a lot of long night conversations with Dr. Atkins, and I was like, oh, I see myself getting a PhD eventually, but maybe not now. And she just kind of looked at me and she's like, why not? why don't you just kind of go into this now? She's like, why, if you have everything that's kind of set up for you, you have this momentum going and you really love it, why isn't it something that you can do now instead of waiting later? And I was like, you know what? You're actually right. You are right. This is something that I want to. So I started my PhD program in 2018. And so I just finished my second full year, finished coursework. And I was just telling her I finished with coursework forever. So I'm actually very excited. And I am in the midst of framing my dissertation, and I just picked my dissertation committee. So my dissertation will mainly focus on disparities within using a national representative sample of Medicaid for HIV positive individuals, looking at not only disparities between HIV positive and HIV negative women on Medicaid, but also looking at antiretroviral therapy use, the differences in provider characteristics and how that influences their birth outcomes. And then my last aim will focus on the comparison between Medicaid and actually military data. So we're comparing Medicaid and Department of Defense data, looking at some of the top 5 maternal and child health outcomes for military women and then also Medicaid beneficiaries. So I'm actually very excited. If she kind of clicks next, just one click. This is my cohort. They are my family here. They are amazing. We are very large for my department, and I think we cost them a lot of money because we are the only large cohort here. But I'm one of 8 of my year. But if you see me anywhere on campus, I am usually with these individuals. And so I love them to death, and they are definitely helping me get through all of the trials and tribulations of my PhD program. You can go to the next slide. So I kind of want to jump into kind of piggybacking off of what Dr. Daniel Atkins was talking about when it comes to health disparities. And so I want to introduce you guys to a project that I actually worked on this past summer. I started this project in May, and it is completely eye-opening. And this is something that will continue to work on in my time here at Brown. So looking at health disparities in Rhode Island and exactly what decides or what influences the different disparities that you see, not only between race and ethnicity, but the disparities that you see between adults and children or different age groups. And so I work with the Hassenfeld Child Institute here at Brown. And this is one of the main points that we actually look at is wellness in Rhode Island and how it's influenced by not only your race, but how much you make, the education that the parents have, and also the zip code that you reside in. Rhode Island is a very unique state. I have kind of figured out that you can pretty much divide income, race, education down to the street. It is block by block, and it is the most fascinating yet heartbreaking thing I think I've ever seen. So this was actually a story that was published in our Providence Journal back in 2018, and this highlights a story. Highlights the story of an individual named Jalen Hare. And back in 1995, in Rhode Island, lead poisoning in children was beginning to emerge as like this public health crisis. It was this one thing that was kind of known in medical circles, but outside those medical circles, people were really not really familiar with the effects of lead had on individuals and especially children. So lead, the ingestion of lead in many different forms, not affects every system in the body, and children are particularly vulnerable to the ingestion of lead, and it can cause many ailments, within infancy, such as like low birth weight, and then things that kind of hold on to you throughout the rest of your life, such as like asthma. And the one thing about Rhode Island is that many people don't know is that our buildings, our homes are incredibly old. um, and with that, kind of age, with a lot of the buildings and a lot of the structures in place comes, lead paint, lead piping, also just and exposes children, especially children living in poverty, to kind of these health risks that other children may exactly not face. We can go to the next slide. So here we have the Children's Health in Rhode Island, and this one kind of breaks it down by the actual town in Rhode Island. And I know many of you don't know because you guys don't live here, but the ones with the highest percentage, the last column, the percentage confirmed blood level, the highest percentage, so Central Falls is actually one of the most impoverished towns and cities in the state of Rhode Island. And the percent confirmed blood level for lead, so being over 5 micrograms of lead in your system, is the highest in the poorest areas, and then also the areas with the highest minority kind of concentration. So another thing that people don't know about Rhode Island is that the number one minority group in the state of Rhode Island is actually Latinx. There's a very large Latinx, Hispanic, Spanish population that resides here, and so usually. So in a lot of those minorities usually congregate in certain areas. So Central Falls is one area, Cranston is one area, I believe certain areas in Providence and also Pawtucket as well. You can go to the next slide. So this one kind of breaks it down by health and race. So kind of piggybacking on what was mentioned before. So race and ethnic disparities and access to healthcare for Rhode Island residents. So as you can see, it breaks it down by Hispanic and Latino, Black and African American, Native American individuals, Asian and Pacific Islander, and then of course white, and then its comparison across the state. So for the percent of adults age 18 to 65 who reported having no health insurance at all, you see that 41.2% of those individuals are Hispanic. And then the next in line is usually Black and African American individuals. The same carries for the percent of adults who had no routine checkup within that past year. So no routine checkup being seen by a primary care physician or has a primary care physician available to them. And that is also Hispanic and Black and African American. The third column is percent of adults who reported having no person they thought as their personal healthcare provider. So not even having a PCP, like a number that you would just call, like I need a checkup. This number is actually very consistent with the amount of individuals who use the emergency room as well within the state of Rhode Island. So instead of having that PCP, instead of having that primary care physician, those individuals are utilizing other services, either free health clinics. We have this thing in Rhode Island called health equity zones, or HEZs, and then also the emergency department, but not necessarily using primary care. And then we have our last column, which is the percent of adults who reported being unable to afford to see a doctor when they needed at least one in the past year. So a lot of individuals who are staying or living in poverty, who necessarily don't have health insurance, maybe because health insurance is offered through your employer, like Dr. Atkins explained before. And then also them not being able to afford to see a physician in the first place because they either do not have health insurance. I know there's a lot of stigma around using healthcare professionals, even when going to the ED in the first place. And then also, not knowing what that cost will be because, the healthcare system is so amazingly set up where you can't see the pricing of a lot of things. So having that fear of what something may cost you, where they just decide they're like, okay, I'm just not going to go to a doctor at all. Just a little statistics kind of about Providence that kind of goes with this. So I believe like 11.5% of white adults report they're unable to afford to see a doctor who need at least once in the last year. So 31% for Hispanics, 17.3%, as you can see, for Blacks and African Americans, and then 21.6% for Native American. And then this is kind of related to, 11% of the white population in Rhode Island is actually living in poverty, compared to 30% of the Hispanic and Latino population is living in poverty, compared to 28.4% of Black and African American, and then 42.2% of the Indigenous population. So a lot of these numbers are very congruent. You can go to the next slide. So this one kind of relays health and then kind of those high income or wealthy areas within Rhode Island. So this kind of breaks it down from the blue to the yellow to the red. So the percent of housing units built before 1950. So like I said, old housing equates to lead paint and lead piping and a lot of health hazards. And so like lead dust. So 0 to 29% are the blue areas, and those equate to some of the more one rural and then two ruler areas of Rhode Island, but also some of the more wealthy areas in Rhode Island. So that's when you start getting into like tourist cities such as like Newport, or you start getting into areas of Providence, what we call Blackstone Avenue, which is where a lot of physicians live, a lot of the politicians live, and things like. And those are those blue areas that you see towards the top. And then you have actual Providence, which is like downtown. A lot of areas in Cranston, Central Falls, and that's where you see where those red areas are. And so those are usually those older homes. And then how that overlays into the next state map, where the percent of families living in poverty and how those kind of correlate. And then the last one, where the percent of elevated blood level for lead is kind of superimposed on individuals living in poverty, and then also individuals living in older homes. You can go to the next slide. So my project this summer especially kind of like took all of this and worked with a Rhode Island Medicaid data set looking at children. So as you know, Medicaid provides health coverage for low-income people, families and children, pregnant women, the elderly, and also individuals with disabilities. So Rhode Island expanded Medicaid in 2014 in order to offer Medicaid to more individuals. They expanded eligibility. That was the main criteria. And with this, total Medicaid and CHIP enrollment expanded to around 300,000 individuals. And with child Medicaid and CHIP enrollment, there was a little bit more than 116,000 of them. So Medicaid covers nearly half, or 50%, of all of the children in Rhode Island. And so these children, the 116,000 from above, are 40% of the total Medicaid enrollment for the state of Rhode Island. So they are the largest group when you compare them to pregnant women, the elderly, and also individuals with disabilities. So we have this kind of information system called KidsNet. And with KidsNet, there's over 190,000 children in KidsNet. So they started tracking these children in January of 2005. And then, the first kind of like data collection was in 2016. And so 149,000 of these individuals with their information in KidsNet is actually linked to maybe birth certificate data of where we can see, kind of like where they were born, when they were born, some really great information. So we can kind of track them throughout their lives. So of these KidsNet individuals, 109,000, so 53%, have ever been enrolled in Medicaid. So they've either, maybe have hopped on and off of Medicaid, but they have been in the system at one time or another. And then 30% of them, or a little bit over 32%, have been continuously enrolled since birth. So they have never lost Medicaid coverage. So a reason why some individuals would maybe lose Medicaid coverage is maybe their parents got a different job, that they're no longer living below the federal poverty line, or they no longer qualify for Medicaid benefits. But 30% have been continuously enrolled since birth, so living below that federal poverty line. So this summer we were looking at like HIDIS quality measures. So HIDIS is this national, it's in conjunction with the National Committee for Quality Assurance tool that measures performance in healthcare. So measures performance through the use of health plans. So health plans like Medicaid. So they collect and report annually by health plans across the 6 domains of different categories and criteria. So looking at effectiveness, people's access to care, their experience, how much are they using the healthcare system or within that certain area or state, the healthcare descriptive information, and also measures collected using the electronic clinical data system, so like EHRs and things like that. And so this data is then used to evaluate the quality of care, and that's determined through a very nice and very simple calculation. So basically taking for a certain measure, let's just say a certain measure of going to get a checkup, making that one up, going to get a checkup. So let's say you're supposed to get one checkup by the age of 1. So we take the individuals who received a checkup during their first year of life, and then the individuals in the denominator of who was 1 during that measurement year. So those who received a checkup, and then those who were eligible to receive a checkup. And you just do kind of like the simple percentage there. And so that's how usually HIDIS quality measures are calculated. Go to the next slide. So with this one, we're just looking, this is kind of one of the resources tools that I liked. Missouri has really great ways of looking at different measures. They make great graphics, so I always go to Missouri. And so like looking at different key pediatric measures, and as you can see, out of the 90 different HIDIS measures there are for quality, about 25 of them are specifically for pediatrics or specifically for infants and children. And so as you can see, this one is like a well child visit, and it lays out the criteria for like the first 15 months, seen 6 or more times or on or before their 15-month birthday. If you kind of click again, the next one is looking at like childhood immunizations. So did they receive their DTaP, their Hep B, the MMR, measles, influenza, and rotavirus, and things like that. You can click again. And this is just another example of, when you are older, for individuals who are 16 to 24, looking at chlamydia screenings. So women who are identified as sexually active, who had at least one chlamydia test in that measurement year. And so if you go to the next slide. So within this data that I was looking at this summer, I had about 12 years of data. So the oldest individuals in my data set were 12 years old. And I had about 104,000 children that I split up into all of these different categories. So whether they were an infant, just 1 year, toddlers, preschoolers, middle childhood, and then young teens, which are only my 12-year-olds. My 12-year-olds were in one group, and that's it. And then it was split 52% male and then 48% female between all 104,000 children. And so if you go next, so kind of tying it back into kind of like that lead exposure, I wanted to look at how many individuals received their lead screening within the state of Rhode Island on Rhode Island Medicaid. So taking that really nice measurement that we did before, at least one capillary of venous lead blood test completed by their 2nd birthday. So looking at individuals who are eligible to receive lead screening and actually individuals that did receive the lead screening. And as you can see within Rhode Island Medicaid, that it hovers just below 50% within the most recent years. 2011 is our special year here in Rhode Island across all data sets that you would see in Hassenfeld. 2011 is just low. I have no idea why. However, we expected this number to be so much higher. But, with this data set within Rhode Island Department of Health, within KidsNet, I'll report very similar findings showing that individuals on Medicaid, so our most vulnerable children, our children that are living in poverty, are not receiving the proper lead screening that they should in order to avoid a lot of these adverse effects. Like I was saying before, it can lead to low birth weight. It can lead to asthma. Is with my example before with Jalen Hare, he received permanent brain damage that he is now facing now at the age of like 25 years old. And so how can we combat this, or how can we have our most vulnerable children receiving the proper screening that they need? And obviously, because they're living in older homes, they are low income in the first place, and then they are subject and exposed to so many different things than other individuals who may not be. And so I have another example, if you go, and this one is also, so preventive medicine services. So these are just looking at just visits for services for like infant measurements of like length, height, BMI, age, and then also like gender appropriate exams. And you see something very similar as well, of where the screening, or for those individuals who are meeting 6 or more preventative medicine services within, by age 2, usually in the first year. I was very lenient with this measure, and this percentage is still under 40%. So showing that our, Rhode Island Medicaid children that are covered by Medicaid aren't receiving the proper services that they need. So how do we kind of affect this disparity as the Rhode Island Department of Health or within the Hassenfeld Institute? So if you go to I believe, yes. So that's my very short kind of overview of what I've been doing for, just one of my projects this past couple of months. The showing that health disparities is really an issue, and especially if you look at it even at a state level, that health disparities not affects, the most vulnerable people, which are, impoverished children, especially in the state of Rhode Island. So happy to take some of your questions. I know that was a lot of information, so I apologize for that, but yes, thank you.
No, that was great. What a great macro and micro view that you guys have given both of us. So we'll just start out with the first question, which is essentially, there are disparities not only in the United States as a whole, but at the state level. Do you think it's possible to be fixed on a large scale, and what does that look like?
Well, I mean, I think that's the goal, right? But one of the things that Catherine highlighted is that the local context matters. And so, expanding access to Medicaid is associated with improved access to care and better health outcomes in many ways. But we also have to kind of drill down at a more, like you said, micro level and say, okay, well, what do these look like when we look within this state? What does it look like? Is there variation within the state? And then the more information we have, right, then we can develop policies to hopefully address those. There is this, often a disconnect, though, between the research and the policy that's made. That we're currently experiencing lots of different types of information coming out with respect to COVID, and there's so much that we don't know and that we're learning so rapidly, and how different community leaders and policymakers are trying to incorporate that into policy. So, I think that's the idea. But one of the things we talk about in policy class is how broad sweeping change is really, hard to do. Most policy change is incremental, and the government was designed that way, right? For lots of good reasons, for there to be checks and balances. So we really don't see, you can go back in time and think about the New Deal, and then all the attempts at healthcare reform that failed until the Affordable Care Act. So I think that's a great question. And these are wicked problems that certainly, need to be addressed.
Definitely. A question to Catherine. When researching the lead amounts in individuals, are they also researching the reason that there's so much lead?
Yes. And so this is actually a project that's being taken on right in partnership, not only with the Hassenfeld Institute here in Rhode Island, but also at the Rhode Island Department of Health. And, other states have kind of implemented similar mechanisms. So you not only looking at the amount of lead, but also looking at like, where is this lead coming from? Is it a housing issue? Is it coming from lead paint, which is, a very large reason why, children are kind of like going around, they're always touching things and in things and putting things in their mouths. So that's one big indicator. And then also to, like I said, Rhode Island is very old. There's old lead piping in a lot of the buildings, and they still exist. And if you kind of go on the Rhode Island Department of Health website, they actually have like schematics of this, of where you can actually see it, lead piping that still exists, and it goes down to the street. So we're on one side of the street, lead piping exists, and literally on the other side of the street, where the income might be a little bit different, there is no longer, old lead piping that would affect individuals. So yes, there's many different ways, and there's a lot of researchers who actually look at the different mechanisms in which lead gets into children's systems.
I think just to follow up on that, it's such a good question that you asked, because it highlights the first thing we have to do to get at solving these problems, which is defining the problem. You have to know what the problem is, right? And there's so many, we think we know, but maybe we don't. And one way to address that is to, engage the community and talk to the community and learn more about what the community sees the problem and how, we meet the community where they are with respect to research. So something that, certainly I think we want to be aware of and do more of.
Yeah. The follow-up, this is one of our participants who's also a city engineer, is asking if Rhode Island is also including looking at their local municipal capital improvement plans to repair the infrastructure.
Yes. Oh, this has been an ongoing conversation. Yes. So that's why I kind of say, like, public policy is health policy, and that is definitely, in this case, that is the utmost truth. So the Rhode Island Department of Health is working with state legislators in order to eradicate the problem. However, it is very expensive. So, allocation of funds towards, rebuilding, lead piping or resurfacing lead paint in homes can often be expensive. And then also with Rhode Island legislature, a lot of that falls on the homeowner. So if the homeowner does not want to, I think that they're supposed to have it within certain levels, to make it safe in a livable space. But however, certain levels or safe levels may not necessarily be the safest. There are still, lead paint or exposure to children that can harm their health. And so I think like they meet that threshold. However, it's not completely eradicated. I remember when I moved to my first apartment here, there was a large notice on the faucet that just said, please watch out for, your ingestion of this water, because too much of it, you could have too much lead within your system. And I was like, where am I living? But it was a very old building. It was beautifully kept in the inside, but it was just an old building, and that's how a lot of places are here. So it is, especially when it comes to like legislation, I think there definitely needs to be statewide action, and there is at a certain level. However, it's the research that's done by researchers and students, and also like Dr. Atkins said, kind of like at that ground level, that root, really getting into those communities to find out where the problems are. And I think that there needs to be a lot more of that. There's headway, but a lot more can be done for sure.
Awesome. Well, thank you guys so much. This was an amazing presentation. It will be accessible on our YouTube channel for anyone that would like to see again or share. Again, thank you, Danielle Atkins, Catherine Thompson. Invaluable information and definitely relevant for today's times working in healthcare, the policy and the disparities that we're definitely seeing happening with COVID-19. This is our department contact information. Definitely reach out to us if you would like to reach out to Danielle Atkins, and then follow us on social media, because we definitely have more of these happening. Danielle will be back with us in our last one on September 2nd, talking more about policy and healthcare information. But thank you again, all of our participants. Thank you, our panelists, and everybody have a great day. Bye.
Bye, everyone.
Bye. Thanks so much.